Xin chào tất cả các bạn. Xử trí hạch nách trong điều trị ung thư vú là vấn đề quan trọng, đặc biệt ở những bệnh nhân giai đoạn sớm. Hôm nay chúng ta sẽ được bác sĩ Terry Mamonas đến từ Viện Sức khỏe Ung thư Orlando trình bày về những cập nhật xử trí hạch nách từ Hội nghị về chuyên đề điều trị ung thư vú tại San Antonio năm 2021. Vì bài trình bày này khá dài nên mình sẽ chia làm hai phần. Phần này sẽ tập trung nói về sự phát triển của não hạch nách, vai trò của sinh thiết hạch đánh gác, cũng như cách xử trí kết quả sau khi sinh thiết hạch đánh gác cho bệnh nhân ung thư vú giai đoạn sớm. Chúng ta cùng bắt đầu nhé.
It's my pleasure to discuss updates in management of the axilla, as we heard in the San Antonio breast conference about a month ago now. And just as an outline of what I would like to talk about the next 40 minutes or so, I mainly focused on an educational session on axillary management. I had the pleasure and privilege to participate, and we'll discuss axillary management surgery, the upfront surgery setting, and also axillary management after neoadjuvant chemotherapy, and some options for reducing risk of lymphedema after axillary lymph node dissection with or without nodal radiotherapy. And within that context, I will weave in three other oral presentations that were presented in different parts of the meeting, mostly actually on the last day on Friday in San Antonio, looking at preservation of axillary lymph nodes compared to a complete dissection in T1 to T2 breast cancer patients presented with one or two metastatic sentinel lymph nodes, the so-called Synodar One Trial that we heard in San Antonio. Another trial, the INSEMA trial, that had patient-reported outcomes, reported again in the San Antonio meeting. And last, a presentation from Memorial Sloan Kettering looking at the impact of race and ethnicity on the incidence and severity of breast cancer-related lymphedema after axillary lymph node dissection, which were results of a prospective screening study. So this is what I will cover in the next 40 minutes or so. So talking about axillary management in upfront surgery, and Dr. Stephanie Wong gave a very nice presentation at the educational session on the local management of the axilla with the title of Local Control, Staging, or Both. And primarily what I will focus on that presentation is the three topics that you see here. How we evolved in axillary surgery for patients that present with clinical and zero disease. Focus on patients that have sentinel lymph node biopsy positive disease and undergo mastectomy, which is still an area of controversy. And also another very hot topic, whether sentinel lymph node biopsy is warranted for all clinical and zero patients, or whether it could be omitted in selected patients. So let's talk about the evolution of axillary surgery in clinical non-negative patients. And as you know, this evolution really started when we saw the results of the NSABP BO4 trial, which was a trial that the NSABP conducted from 1971 to 74. And it had actually two arms, the clinically non-negative patients and the clinically non-positive patients. So we'll focus here on the clinically non-negative patients, about 1,159 patients that were randomized to the then standard of radical mastectomy, which included, of course, unblocked axillary lymph node dissection, or total mastectomy with radiotherapy instead of axillary dissection, or total mastectomy with observation. So obviously three different approaches in the management of the axilla. And when you actually look at the control rate in the observation group where no axillary dissection was performed, about 17.8% of the patients suffered an axillary recurrence. But when you actually look at the group that received radiotherapy, only 3.1% of the patients had a recurrence. And those that had the axillary dissection as part of the radical mastectomy, only 1.4% of the patients had a recurrence. This is despite the fact that when you had the radical mastectomy and had an axial dissection, 40% of those patients were found to have subclinical disease in the axilla. And of course, that the day the axillary assessment was done by the finger of the surgeon, palpating the axilla and see if the lymph nodes are palpable. So despite the fact that the surgeon thought that the nodes were clinically negative, about 40% had disease, very well controlled with an axillary lymph node dissection, fairly well controlled with radiotherapy, only 3.1%. But even with observation, only half of those patients, less than half, ended up having a recurrence in the axilla. So axillary dissection, had very good local control, as we see, and also provided accurate staging. And of course, we all know that the long-term results of the study showed that the elective axillary dissection did not change overall survival or recurrence-free survival. This is the woman with clinically negative nodes, as we discussed before, and you see no difference between the three arms. So despite the fact that there was no survival benefit, axillary dissection continued to be performed for the purposes of local control and for the purposes of staging, when staging was important for prognosis and also potentially for prediction of what therapy the patient would need. And of course, the whole evolution with sentinel lymph node biopsy occurred. And here we see that eventually we had done many randomized trials. Two of them I show you here. The Milan trial was the first to be reported with 500 patients, and then the NSABP B32 trial with about 5,600 patients, evaluating sentinel lymph node biopsy alone for patients who have clinically negative axilla and a negative sentinel lymph node versus completion of the axillary lymph node dissection. And as we see here, the false negative rate was at the time 8.8% in the Milan, 9.8% in B32 trial. Remember, these were surgeons that were trained at the time to perform sentinel lymph node biopsy. It was they were both multi-center trials. But what's very interesting also that was axillary recurrence was very low in both arms, in both trials. 0 for the Milan trial and less than 0.5% for the B32 trial. So again, accurate staging with the sentinel lymph node biopsy was provided, and effective local control just with the sentinel lymph node biopsy without completing the axillary dissection, despite the fact that about, as we will see here, in the Milan trial, 35.5% of the patients, when they had the sentinel lymph node biopsy, were found to be sentinel lymph node positive. In the B32, only 26% were found to be sentinel lymph node biopsy positive. And of course, these patients all underwent axillary dissection. We're focusing on the patients that were found to be sentinel lymph node negative. So it's interesting also from the B32 trial to note that for patients that had clinically negative disease and underwent sentinel lymph node biopsy, and the sentinel lymph node was positive, and then had an axillary lymph node dissection, in 61.4% of the cases, the sentinel lymph node was the only positive node identified, which means that those patients did not have any therapeutic benefit potentially from the axillary dissection because all the remaining nodes that were removed were negative. And of course, this actually started us thinking that maybe we don't only apply this concept to clinically non-negative patients with negative sentinel node, but we can maybe apply it to clinically non-negative patients with limited involvement of the sentinel lymph nodes. And of course, that led to the conduct of several trials that you're probably aware of by now, that compared essentially completion axillary dissection to no further surgery for patients that have limited involvement in the sentinel nodes, either in terms of micrometastases, such as the IBCSG 2301 trial, or the AATRM trial, a smaller trial. You see here less or equal to 2 positive macrometastatic sentinel lymph nodes, or more than 1 or more in the AATRM. And then, of course, the pivotal Z11 trial, right? From the Alliance, from the ACOSO group at the time, that took patients less or equal to 5 centimeters with less or equal to 2 positive sentinel lymph nodes. All these patients had breast conserving surgery and then randomized into axillary lymph node dissection versus observation. And eventually, as you will see in the next couple of slides, I showed no difference in overall survival. And of course, there were some other trials, the Amaros trial, the Autosort trial, that actually took the same group of patients, but the randomization was to either completion axillary dissection if the sentinel lymph node was positive versus axillary radiotherapy. And we'll see the results of the Amaros trial next. But what's important here is that in the Z11 trial, all the patients had breast conservation, so they received breast radiotherapy that could have affected some of the local control in the axilla. But some of the other trials had some mastectomies, but not a lot. We see the IBCSG and the ATRM, 91% of the patients had breast conservation, 88% in the ATRM. And in the Amaros and the Autosort trial, we see 83 and 84%. So the majority of the patients we're talking about here are breast conservation patients. Interestingly, the axillary burden, in other words, the probability of having positive non-sentinel nodes varied as one would have expected, and it was about 13% if the sentinel lymph nodes were positive for micrometastatic disease. It was about 27% in the Z11 trial, and it was even higher in the Amaros and the Autosort trial, 33 and 39%. So that's very interesting because we know that we can leave substantial disease behind, and either radiation will take care of it or systemic therapy will take care of it, but the outcomes are very good, as you will see. And of course, the Synodar One is another trial that I will discuss in more detail because it was presented in San Antonio, having exactly the same design, positive, less or equal to 2 sentinel lymph nodes, axillary lymph node dissection versus observation. That trial also included about 22% of mastectomy patients. So when we look at the results of the Axillary Z11, we see, again, no difference in disease-free survival, no difference in overall survival. If anything, the sentinel lymph node group here was a little higher than the axillary lymph node dissection group. And perhaps more importantly, 10-year axillary recurrence, 0.5% with axillary lymph node dissection and only 1.5% with sentinel lymph node biopsy alone. So despite the fact that about 26% of the patients had positive non-sentinel nodes that were not dissected, we see not much difference in axillary recurrence. And these are the results of the Amaros trial comparing completion axillary dissection versus axillary radiotherapy. Again, we see no difference in disease-free survival or overall survival, and very good local control in the axilla, 0.4% versus 1.2%. So with that, of course, sentinel lymph node biopsy became the standard for patients that either have 1 or 2 positive lymph nodes. And the debate is whether you can just do observation or give axillary radiotherapy. We'll discuss that in a minute. Now, this slide summarizes the rates of axillary recurrence in all these trials. And you can see that whether you had axillary dissection or observation or axillary dissection or radiotherapy, the rates of axillary recurrence, even in the worst case scenario, they weren't any more than 1.7%, mostly 1.5%, 1.2%, 1%. Very good local control of the axilla just with the sentinel lymph node biopsy. So for patients with clinical and zero disease that were treated with upfront surgery and had 1 or 2 positive sentinel nodes, it's fair to say that sentinel lymph node biopsy provides accurate staging and effective local control. Now, the controversy started on mastectomy patients because obviously they may have more extensive multicentric disease. They don't typically receive incidental radiotherapy to level 1 of the axilla. That occurs in the majority of patients that are treated with breast conserving surgery and undergo whole breast radiotherapy. And of course, the guidelines for that have changed over time because now most of the patients with any positive lymph nodes are discussed at least for receiving some form of radiotherapy, whether they have mastectomy or breast conservation. And of course, these patients were also, as I mentioned before, less represented in clinical trials. So we see here, as I discussed before, that in the IBCSG 2301 and ATRM, the mastectomy patients were only 9% and 12%, and a little bit more in the amorous and the Dr.Trương trial, but the majority again of the patients were breast conserving patients. So what about the mastectomy patients? Well, given that most of these patients potentially would receive radiotherapy, if clinical N0 patients undergone mastectomy and have sentinel lymph node positive for micrometastasis, I think it's fair to say that most would agree that no further axillary treatment is necessary, and even radiotherapy can then be omitted in these patients. For clinical N0 patients undergoing mastectomy and have 1 to 2 positive sentinel lymph nodes for micrometastasis, we know that axillary radiotherapy provides effective local control in the amorous Dr.Trương trial in those patients for which post-mastectomy radiotherapy is indicated. And in addition, axillary radiotherapy results in less lymphedema in the axilla compared to surgery. So there is really no reason to do an axillary dissection unless you will change something by knowing that the patient has, let's say, 4 or more positive sentinel lymph nodes, or for whatever reason, if the radiotherapist says that they would not radiate the patient if you did an axillary dissection and you didn't find any additional nodes, and because the patient has reconstruction, you want to avoid the radiotherapy, I think that may be an indication for the axillary node dissection. But in general, if radiotherapy is to be considered, then completion axillary dissection does not therapeutically add anything to these patients, even if they have a mastectomy, again, although they were relatively underrepresented in the clinical trials. So that brings us to discuss the Synodar One Trial, which again is another trial that adds to the evidence that sentinel lymph node biopsy alone is effective approach for patients with 1 to 2 positive sentinel nodes. This is a multi-center trial from Italy, including T1 to T2 breast cancer patients with 1 to 2 metastatic sentinel lymph nodes, and it was presented again in San Antonio this past December. The study design is very similar to the Z11 trial. Patients with T1, T2, and 1 by positive sentinel lymph node, 1 to 2, and clinically negative axilla, but with axillary ultrasound on top of the fingers palpation. And 889 patients were randomized to completion axillary dissection or sentinel lymph node biopsy. Adjuvant treatment was given according to institutional standards and multidisciplinary meeting discussion. So when we look at the axillary treatment results, we see that the average number of sentinel lymph nodes was about 2. The majority of the patients that had positive sentinel node had only 1 positive lymph node, 341 patients here in the standard arm and 326 patients in the experimental arm. But about a quarter of the patients, 96 here and 110 there, had 2 or more sentinel lymph nodes, and very few had 3. As you can see, only 1 patient here and 2 patients here. The involvement of the nodes was mostly by macrometastasis. That's the difference between this trial and the AquaShock Z11, where about 35 to 44% of the patients had micrometastasis in that trial. So only 2 patients had only micrometastasis in the standard arm, and only 3 patients had micrometastasis in the experimental arm. And axillary dissection here was supposed to be the standard, and it happened in 417 cases. There were some deviations, 22 cases did not, and the opposite happened in this arm. Axillary dissection was not performed in 427 cases, but there were 13 patients who had opted, for whatever reason, to have an axillary dissection. 44% of the patients, and that's important, 44% of the patients in this trial had positive non-sentinel nodes. So the axillary burden was higher in this trial, even twice as much than in the AquaShock Z11 trial. The mean positive non-sentinel nodes was 1.41. And obviously, this trial again put to the test the fact that we do leave lymph nodes positive behind if we do just a sentinel lymph node biopsy and not an axillary dissection. When you look at the primary tumor surgery, you see that about 24% or so, including this patient here, had mastectomy. And also in the other arm, experimental arm, about 23% of the patients had mastectomy either up front or after breast conservation and eventually mastectomy. So again, more representation of mastectomy patients in this trial. The median follow-up was short, 33.3 months actually in the standard arm and 34.5 months in the experimental arm. But overall, even with a short follow-up, so far there is no evidence of difference in recurrence-free survival as we see here and overall survival as we see here. And the outcomes were actually very good for both groups of patients. So if you compare side by side the Z11 and the Synodar One, obviously the Z11 much more follow-up than the Synodar One. When it comes to the involvement of the sentinel lymph node, again, a lot of micrometastasis in the Z11, 37.5% in the axillary dissection arm and 44.8% in the sentinel lymph node biopsy arm. Very small involvement with micrometastatic disease in the Synodar trial. When it came to detailed radiotherapy data, we had only about 24.8% or 28.4% in the Z11, but the majority of the patients, 3/4 of the patients in the Synodar One allegedly have very good radiotherapy data, which obviously we look forward to hearing results from. And the majority in both trials were luminal tumors, a little bit more in the Synodar trial, 82 and 80% were luminal tumors. And of course, no mastectomies were included in the Z11, but 23% of the patients had mastectomy in the Synodar One. So there are also other trials that will address this question. The post-NOC trial is a UK trial that takes patients with clinical T1 to T2 unifocal or multifocal breast cancer undergone breast conservation with 1 to 2 macrometastasis in the sentinel node, much larger trial here, 1,900 patients, and randomize them to standard adjuvant therapy or standard adjuvant therapy and axillary treatment, which in this case could be either axillary lymph node dissection or axillary radiotherapy. And the primary endpoint is 5-year axillary recurrence, secondary endpoint morbidity, quality of life, and local regional disease-free survival and overall survival. So an important trial, particularly if it goes to full accrual and has 900 patients. And then in the US, we now have another trial that addresses actually the potential need for radiotherapy for these patients. So this is a Taylor RT led by the Canadian group that takes ER-positive HER2-negative patients that have a low oncotype score, less or equals to 25, and either have macrometastasis with 1 to 3 positive lymph nodes, treated either with breast conservation or mastectomy, including also T3 and 0. And the target accrual is 2,140 patients. And the randomization is between no regional radiotherapy versus regional radiotherapy. And of course, if you have breast conservation, you get whole breast irradiation with or without regional radiotherapy. If you have mastectomy, you get no chest wall radiotherapy or no regional radiotherapy in the experimental group. In the control group, chest wall and regional nodal radiotherapy. And the primary endpoint is breast cancer relapse-free interval. So a very important trial too to define whether we do need radiotherapy for these patients with a low burden of disease in the sentinel lymph node or axillary dissection, but also a low oncotype score. So the next question that Dr. One addressed, as I mentioned earlier, was can we further de-escalate axillary management in clinical N0 patients undergoing upfront surgery? In other words, is even sentinel lymph node biopsy necessary for these patients? And if there is no sentinel lymph node biopsy, would local control be compromised? Now, this concept is primarily applicable today to postmenopausal patients with hormone receptor positive HER2 negative disease, because premenopausal patients typically need to have an axillary dissection to decide whether they need chemotherapy or not, based on obviously the genomic profiling test. And also the triple negative and HER2 positive patients typically receive neoadjuvant chemotherapy, where we really need to know if there was residual disease in the lymph nodes, because that decides also adjuvant systemic therapy after the neoadjuvant therapy. So we'll talk a little bit about that later on. We'll talk about neoadjuvant chemotherapy. So, but for the postmenopausal ER-positive HER2 negative, the knowledge of the status of the axilla usually doesn't change systemic therapy. So can sentinel lymph node biopsy be avoided safely in those patients, and is local control compromised? There are a couple of trials that actually were conducted looking at that, and a couple that are ongoing. This all started with CLGB 9343, which was a trial in women 70 years of age or older with ER-positive clinical or negative breast cancer that had breast conserving surgery. The question was, do you need radiotherapy to the breast or not? This was the main question of the trial: randomization to tamoxifen for 5 years or tamoxifen plus radiotherapy. And what that study showed was the radiotherapy controlled the disease in the breast better, 2% ipsilateral breast tumor recurrence versus 10% without radiotherapy. But also radiotherapy controlled very well the disease in the axilla, with no recurrences in the radiotherapy group and only 3% in the tamoxifen alone group. But in this trial, axial lymph node dissection was allowed, encouraged, and about 62% of the women did not undergo axial lymph node dissection. This was pre-sentinel lymph node biopsy. It was 94 to 99. So despite the fact that 62% of the patients did not have any intervention in the axilla, with radiotherapy, these patients did very, very well, had no axillary recurrences, even without, had very low risk of axillary recurrence. So that started the conversation whether do we need axillary staging for these patients, or can we avoid it? So the rationale, of course, is that there's no therapeutic advantage to performing a completion axillary dissection in these clinical and zero patients that are sentinel lymph node positive and undergo breast conserving therapy. And of course, the sensitivity of preoperative axillary lymph node, axillary ultrasound and core needle biopsy to suspicious nodes is pretty high, at least 80% or more. And a negative axillary ultrasound pretty much excludes the presence of N2 or N3 disease, with a very high negative predictive value, 93 to 96%. So you can select patients that have most likely 1 or 2 positive lymph nodes, if any, that are clinically non-negative, and you can screen them with axillary ultrasound. So there are 2 clinical trials to speak about. The SOUND trial is a trial that takes unifocal clinical T1 and 0 breast cancer, less than 2 centimeters, that undergo breast conserving therapy, have a negative axillary ultrasound, 1,500 patients, and randomizes them to either sentinel lymph node biopsy, with or without axillary dissection if the sentinel lymph node is positive at the investigator's discretion, or no axillary surgery at all. Now, the primary endpoint is the distant disease-free survival. You see here the secondary endpoints. And in a planned ancillary analysis for the first 176 patients, there was noted that there is higher rate of early postoperative disability in the sentinel lymph node arm, 24% versus 10.6%. Significant. So in other words, you do have some problem when you just even do the sentinel lymph node biopsies, now without any potential complications or morbidities. And the bigger trial is shown here, the INSEMA trial, that we'll discuss a little further because it was presented in San Antonio. We see the clinical T1 or T2 here in 0 breast cancer patients with planned breast conserving surgery, and again, negative axillary ultrasound. A total of 6,000 patients were randomized 1:4 to no axillary staging versus sentinel lymph node biopsy. Interestingly, although they allowed T2 patients in this trial, when they looked at the preliminary results with 1,000 patients, the median age was 60 years. 89% of the patients had just T1 tumors. 94% were grade 1 and 2. 97% were ER positive, and only 8.5% were HER2 positive. In other words, the investigators selected really low-risk patients to include in this trial. And when you look at the axillary burden, when the patients had a sentinel lymph node biopsy, 83% were PN0, so in 83% of the patients, obviously no difference here. 16% had PN1, and only 0.4% of the patients had PN2. And in fact, only 1.3% of the patients had 3 or more macrometastases. So in general, this trial shows so far that even if you didn't do a sentinel lymph node biopsy, you wouldn't have missed a lot of disease, only in about 17% of the patients. Some, and very few with 3 or more. Now, we will focus on this trial because it was, as I said, it was presented in San Antonio, and in that meeting, we heard the results of patient-reported outcomes from the INSEMA trial. So obviously, it's an important question because the question is, by just doing the sentinel lymph node biopsy, do you affect the quality of life of patients? Do you affect their arm symptoms or the breast symptoms? Because if you didn't, then the question is, why not? But if you did, obviously it justifies trying to avoid this intervention. So again, this is a schema of the trial, 1-to-4 randomization to no sentinel lymph node biopsy or sentinel lymph node biopsy. And further, there was a second randomization for those patients that had positive sentinel node 1-to-3 to 1-to-1 ratio to complete axillary dissection versus no complete axillary dissection. So the primary objectives is to compare IDFS. Secondary objectives, again, non-inferiority between the sentinel lymph node biopsy, no sentinel lymph node biopsy, or the sentinel lymph node biopsy versus axillary dissection, and the quality of life were the secondary objectives discussed in San Antonio using the ORTC QLQC30 and his breast cancer module BR23. And as you can see, they did baseline and then at 1, 3, 6, 12, and 18 months after the final axillary surgery. So these are the results. It's fair to say that in terms of quality of life, there was no overall significant difference in quality of life between sentinel lymph node biopsy and no sentinel lymph node biopsy. But there were significant differences in the breast symptoms and also in the arm symptoms, favoring the no sentinel lymph node biopsy group. However, these differences you see here were clinically meaningful only when it came to the BRAS score, in other words, the arm symptoms. You can see there's a clinical significant difference in the arm symptoms, but there was no clinical significant differences in the breast symptoms, although a statistical significant difference favoring the no sentinel lymph node group. When you look at the second randomization, comparing completion axillary dissection versus sentinel lymph node biopsy alone, you see again no difference in breast symptoms, although a little bit difference up front, but eventually no difference. And again, significant differences in the arm symptoms in favor of the sentinel lymph node biopsy alone versus the axillary dissection. When you look at the quality of life of arm symptoms separately, looking at pain in the arm or shoulder, you see again difference with sentinel lymph node biopsy versus no sentinel lymph node biopsy, and also difference with completion axillary dissection versus sentinel lymph node biopsy alone. Or more importantly, when you look at swelling in the arm or hand, again, difference both with sentinel lymph node biopsy versus no sentinel lymph node biopsy, but the difference is smaller here, and a lot more difference in the completion axillary dissection versus sentinel lymph node biopsy alone. Not unexpected. These are the patients potentially that have problems with the arm in terms of lymphedema. And when you look at the arm mobility, again, some difference here in the first randomization between sentinel lymph node biopsy versus no sentinel lymph node biopsy, and very small difference between completion axillary dissection versus sentinel lymph node biopsy alone. We do see a difference up front, but that difference kind of goes away over time. So there's more mobility, limitation in mobility with axillary dissection early on, but eventually you get over it fairly quickly. So in summary and conclusions from this trial, with very large number of patients, over 5,000 patients, patients with a known sentinel lymph node biopsy had improved breast and arm symptoms, mostly focusing on the arm symptoms compared to those with sentinel lymph node biopsy. And then in the sentinel lymph node biopsy group, those patients had improved arm symptoms and functioning compared to those that received completion axillary lymph node dissection. There were no relevant differences in other quality of life scales. And again, we're waiting the invasive disease-free survival data from this trial, and we're obviously very eagerly awaited because potentially, if there's no difference, they may change clearly the standard approach to these low-risk patients in terms of whether we electively approach the axilla surgically or not.
Vâng, bài học đến đây đã kết thúc. Phần sau chúng ta sẽ tìm hiểu về cách xử trí chọn lọc hạch nách sau hóa trị tăng bổ trợ. Các bạn nhé subscribe để theo dõi bài học tiếp theo nhé. Xin chào và hẹn gặp lại.